Hi, I'm Peter Gloviczki from Mayo Clinic, Editor-in-Chief of the Journal of Vascular Surgery. I am pleased to introduce to you the best papers of the January issue of the JVS. The editor's choice article this month is a statistical tribute to vascular surgery. It is a network meta-analysis of randomized controlled trials comparing treatment modalities for occlusive lesions of the superficial femoral artery. The authors analyzed results of 33 randomized controlled trials that compared 11 treatment modalities in 4,459 patients with claudication or critical limb ischemia. The paper includes interesting network plots for primary patency and restenosis. The width of the line in these plots is proportional to the number of trials comparing each pair of treatments, and the size of each node is proportional to the sample size in the trial. The network meta-analysis permitted comparisons of different treatment modalities and the ranking of them for patency and restenosis. The rank order from higher to lower 1-year primary patency was drug-eluting stent, nitinol stent, and covered stent. To prevent restenosis, combination treatments with nitinol stents, cryoplasty, and drug-eluting balloons were the most effective. The next paper from Johns Hopkins Medical Institutions by Arhuides and colleagues is entitled Stenting versus Endarterectomy after prior ipsilateral carotid endarterectomy. These authors reviewed data of 2,863 patients enrolled in the VQI who underwent either carotid endarterectomy or carotid stenting for restenosis after previous ipsilateral carotid endarterectomy. The authors found a significantly higher 30-day mortality in patients who underwent endarterectomy, but the stroke and MI rates were similar, and there was no difference between combined stroke and death or stroke and death and MI rates. The incidence of cranial nerve injury after surgery was 4.1%. 1-year outcome data were identical with similar freedom from stroke in both asymptomatic and symptomatic patients who underwent either endarterectomy or stent. Based on these data, the authors recommend carotid stenting in high-risk surgical patients who need carotid revascularization for restenosis after previous endarterectomy. The next paper is on early infection risk with primary versus staged hemodialysis reliable outflow HERO graft implantation by Dr. Griffin and colleague at Duke University Medical Center. The HERO graft has been used for vascular access in patients with central venous stenosis or occlusion. It is an FDA-approved subcutaneous graft with an arterial and venous component with only one surgical anastomosis on the arterial side, and it is placed endovascularly on the venous side. This retrospective review of 192 hemodialysis patients found that staged HERO graft implantation is a reasonable strategy in patients with complex central venous disease, and it did not result in increased early infection risk compared to conventional primary implantations. Finally, the last paper is on late rupture of abdominal aortic aneurysm after endovascular repair. It was authored by Dr. Sessan Rajendran and Dr. Jim May from Australia. Over a 22-year period, 3.1%, 40 of 1,288 EVAR patients had aneurysm rupture with a mortality of 20%. That was significantly lower than the mortality of 49% of patients who had ruptured aneurysm without any previous repair. This study confirmed again that EVAR does not prevent rupture in all patients. The data also suggests that rupture after EVAR has a lower rate of mortality than rupture of previously unrepaired aneurysms. The authors recommend lifetime surveillance of EVAR patients, especially those with large initial aneurysms, with persistent endoleaks, and with graft migration. These were just a few of the many excellent articles from our January issue. To access these articles free in January, please visit us on www.jvascsurg.org. Enjoy reading JVS journals and see you next time for the highlights of the February issue of the Journal of Vascular Surgery.